If you're over 60, you must know this about calcium, iron, and zinc, because taking them the wrong way can quietly cancel out the benefits you expect. Hi, I'm Dr. Emily Carter. I've cared for older adults as a geriatrician and clinical nutritionist for more than 2 decades, and one thing I see again and again is good intentions meeting surprising biology. You may be careful, consistent, even disciplined with pills and powders, and still not be getting the results you want. Today, I'll explain why, what typically goes wrong, and practical, realistic changes you can make. Before we begin, tell me in the comments, are you taking 1, 2, or all 3 of these right now? Let me give you a short roadmap so you know where we're headed. First, I'll explain in plain language what calcium, iron, and zinc actually do in the body, and why those roles change after age 60. Then I'll walk through the 5 most common mistakes I see, with clear clinical reasons and everyday examples. After that, we'll cover practical solutions, timing, dosing patterns, and what food first really looks like for older adults. Finally, I'll introduce a real patient story, Patricia, to show how small changes can make measurable differences. One more quick note. This is general information, not personal medical advice. If you're thinking about changing your supplements, talk with your healthcare provider and consider lab testing first. Let's start with the basics. Understanding the why makes the what much easier to follow. Calcium. More than just bones. Most people think of calcium as a bone nutrient, and that's true. About 99% of the calcium in your body lives in bone, but that other 1% is critical. It helps your heart contract, keeps your muscles coordinated, and helps nerve signals fire properly. After age 60, bone remodeling slows. Your kidneys also change how they process calcium and vitamin D activation is more fragile. Those changes mean the way you take calcium becomes more important than simply taking a larger amount. A key practical point about absorption. The intestine can only absorb so much calcium at once. Clinically, we often talk about calcium being absorbed most efficiently in doses of roughly 500 to 600 milligrams at a time. Many over-the-counter calcium tablets contain 1,000 million or more per tablet. That's not necessarily wrong, but it's a reason to think about splitting doses across the day, paired with meals, rather than taking a single large pill once. Iron. The energy and oxygen mineral. Iron is central to hemoglobin, that's the protein in red blood cells that carries oxygen, and to cellular enzymes that make energy. Low iron can cause fatigue, poor endurance, shortness of breath with activity, and even changes in mood and cognition. For older adults, iron absorption becomes more fragile for a few reasons. Stomach acid tends to decline with age. Many people are on acid-reducing medications, which blunt iron absorption, and chronic inflammation raises a hormonal regulator called hepcidin that tells the body to hold on to iron and limit absorption. At the intestinal level, iron crosses the gut lining using specialized transport proteins. One you might see mentioned is DMT1, an iron transport protein. That's a useful word to know. In plain language, it's the door iron has to go through to reach your bloodstream. That door can be blocked or slowed by things in your meal: calcium, dairy, coffee, tea, and some medications. Conversely, vitamin C opens the door wider for iron. That's why iron is typically absorbed best with a vitamin C-containing beverage, like a small glass of orange juice, and on an empty stomach or away from calcium-rich foods. Zinc, repair, immunity, and taste. Zinc plays multiple roles, supporting immune cells, helping wounds heal, maintaining taste and smell, and contributing to normal cognition and protein synthesis. Zinc is essential, but it's also competitive. High or prolonged zinc intake can reduce copper absorption and over time produce problems like low copper and even anemia or nerve symptoms if unmonitored. Zinc, like the other minerals, shares parts of the intestinal transport system with iron and copper. So when we use high doses or bundle supplements together, we create competition. Those are the roles. Now let's turn to the mistakes I see most often. Practical, observable mistakes that you can fix right away. Common mistake number 1. Taking calcium, iron, and zinc together. Why this matters? At the gut level, minerals compete. Calcium is particularly effective at reducing iron absorption when taken at the same time. Zinc, in higher doses, can worsen copper and iron balance. If you take all 3 at breakfast in a single pillbox routine, you may be reducing the net amount your body actually absorbs from each dose. People do this because it's simple. They want one time to get everything done. But efficient isn't always effective. After 60, timing matters more than just quantity. Everyday example, Mrs. J fills a daily pillbox and takes her calcium, a multivitamin with iron, and a zinc tablet all with coffee. She expects a benefit, but months later her lab shows low iron stores. The likely culprit, those minerals were competing at the same time in her gut, and the coffee also blocked iron absorption. Common mistake number 2. Taking iron with coffee, tea, or dairy. Why this matters? Coffee and tea contain polyphenols and tannins that bind iron in the gut and prevent absorption. Plain milk or yogurt provides calcium and casein proteins that hinder iron uptake. If your iron pill meets a latte or a bowl of yogurt, much of it may pass through unused. Everyday example. A retired teacher takes her iron with morning yogurt because it settles my stomach. She feels nauseous if she takes iron straight. Over time, she remains tired, and a ferritin test shows low iron stores. Switching where the pill meets the gut, moving it away from the dairy and the coffee, often fixes this. Common mistake number 3. Long-term, high-dose zinc without monitoring. Why this matters? Zinc supplements are popular. Immune health, wound care, cognitive interest. But high zinc over months can suppress copper, and because copper is needed for iron metabolism, that suppressed copper can indirectly worsen anemia and contribute to neuropathy. The more zinc someone takes, especially above typical maintenance doses, the more reason we have to check labs periodically. Everyday example. A man uses zinc lozenges nightly because he believes it supports immunity. He doesn't feel immediate harm, but 6 months later his labs show low copper and mild anemia. The fix is not to demonize zinc, it's wildly useful, but to use it with an eye on duration, dose, and lab surveillance. Common mistake number 4. Taking a single large calcium dose once daily. Why this matters? Because calcium absorption saturates. Taking a single large dose, for example, a 1,200 mg tablet once a day, invites waste. Splitting that total across 2 meals, for instance 500-600 mg with breakfast and the same with supper, usually leads to better absorption and less interaction with other minerals. Everyday example. Many calcium supplements are labeled in round numbers that sound easy, but ease of a single dose can come at the cost of efficiency. Dividing doses and timing them with meals gets more calcium into bone over time and reduces interference with iron absorption if scheduled thoughtfully. Common mistake number 5. Continuing supplements long-term without lab monitoring. Why this matters? Supplements are helpful, but biology changes over time. Kidney function, hormone levels, inflammation, and interactions with new prescription medications all shift as we age. Without periodic lab checks, think ferritin, hemoglobin, or a basic CBC, kidney function, and when indicated, zinc, chart, copper labs. We risk either persistent deficiency or inadvertent excess. Both matter for quality of life. Everyday example. A caregiver reports that their spouse has been taking an over-the-counter complete mineral regimen for years. No one has checked labs in that time. The spouse complains of fatigue and occasional dizziness. A simple CBC and ferritin check reveals iron deficiency anemia that likely could have been caught months earlier. Now that we've outlined the problems, let's move toward solutions, focusing on principles you can actually implement. I'll be precise where it helps and cautious when needed. Principle 1. Separation and timing, overpiling everything together. This is the single most actionable change. Iron should generally be taken away from calcium and dairy. A practical rule I use with patients is to aim for about a 2 to 3 hour gap between an iron dose and a calcium-containing meal or supplement. That's enough time for the iron to pass the most vulnerable section of the small intestine before it meets a calcium-rich environment. Vitamin C enhances iron absorption, so pairing iron with a small source of vitamin C, an orange slice, a few teaspoons of orange juice, or even a vitamin C chewable, is helpful for many. I want to be clear, when I say 2-3 hours, I'm offering a practical, commonly used guideline, not an absolute prescription. Always discuss timing changes with your clinician, especially if you take multiple medications that have their own timing rules. Principle 2. Divide calcium into smaller servings. Because calcium absorption is dose-limited, aim for smaller servings through the day. If your total daily target requires 1,000 milligrams, dividing that into 500 milligrams twice daily often works better than one 1,000 milligram dose. Take calcium with meals. That not only improves absorption for many people, but also reduces the odds of gastric upset. Principle 3. Use zinc thoughtfully and monitor when used long-term. Short courses of zinc can be useful for specific needs, but avoid long-term high doses without lab checks. If you take daily zinc, taking it with food reduces stomach upset and reduces competition with iron at the exact moment of absorption. If your regimen includes higher than usual zinc, ask your clinician about checking copper levels at intervals. Principle 4. Food first approach. Supplements are designed to fill gaps. For most older adults, emphasizing dietary sources, calcium from dairy or fortified alternatives, iron from a mix of heme sources if you eat meat, and iron-enriched plant sources paired with vitamin C, zinc from lean meats, seafood, beans and nuts, gives a foundation. Supplements should be used to correct shortfalls identified by diet assessment or labs. Principle 5. Baseline labs and periodic reassessment. Before changing doses or starting long-term supplementation, get baseline labs when feasible, complete blood count, CBC, ferritin, iron stores, basic metabolic panel to check kidney function, and if zinc is being used long-term at higher doses, consider checking zinc and copper levels. Reassess after a reasonable period, often 6 to 12 weeks for iron interventions, sometimes earlier for symptoms, and adjust with your clinician. Medication interactions to watch for. A quick note on acid-reducing medications. Proton pump inhibitors, PPIs, and H2 blockers are common in older adults and reduce stomach acid. Low stomach acid makes iron absorption more difficult, especially for non-Hem iron, plant-based or supplemental iron salts. If you're on one of these drugs, review iron strategies with your clinician. Sometimes an alternative iron formulation or timing adjustment is helpful, but never stop prescribed medications without provider guidance. That covers the core physiology and the straightforward changes that help most people. Now I want to bring this to life with a patient example. Not because one case proves every truth, but because stories make the practical steps easier to remember. Patricia's story. Patricia is a 74-year-old retired librarian, organized, cautious, and very consistent with her supplements. She kept a small wooden pill box labeled with the days of the week and took it seriously. She told me, "Dr. Carter, I do everything right. I take my vitamins, I avoid junk, I walk 3 times a week. Yet she felt increasingly tired climbing stairs, noticed her hair thinning at the temples, and felt a vague sense of breathlessness when she carried groceries. She also complained of occasional digestive upset. When I reviewed her supplement routine, she had a profile I see often: a calcium supplement taken with breakfast and yogurt, a daily multivitamin that contained iron, and a separate zinc lozenge at night because she believed it was good for memory and immunity. Importantly, she always drank coffee with her pills. The pill box, the yogurt, the coffee all happened within the first 20 minutes of her day. Her labs were revealing ferritin, a marker of iron stores, was low, and her hemoglobin was mildly reduced, consistent with iron deficiency anemia. Because she took zinc nightly and had been doing so for months, I ordered a basic zinc copper panel as well. Her copper was low normal, not yet overtly deficient, but the trend made me cautious. Her kidney function was stable, which made supplement adjustments safer to consider without renal restrictions. This is a classic example of several small things stacking: iron blocked by calcium and coffee, zinc taken long-term without monitoring, calcium given as a single larger morning dose. Patricia was not careless, quite the opposite. She was diligent, but physiology after 60 means those small patterns matter a great deal. We outlined a plan together, not a prescription for everyone, but a personalized approach for her situation. The key elements: move iron to a different time of day, paired with vitamin C, divide calcium into 2 smaller doses with meals later in the day, reduce the zinc dose to a maintenance level, and plan to repeat zinc-toc copper labs, and emphasize iron-rich foods paired with vitamin C at meals. Because she used acid-reducing medication intermittently, we discussed that her iron absorption might still be blunted and agreed to monitor labs closely. We also discussed practical habits she could implement immediately. For example, Patricia agreed to try taking her iron mid-morning, about 2 hours after breakfast, with a small glass of orange juice and a plain cracker if she needed something in her stomach. She would take calcium at lunch and dinner instead of breakfast, splitting her total calcium into 2 doses. She would keep the zinc lozenge, but switch to a lower daily maintenance dose and schedule a copper check in 3 months. We planned for a follow-up lab panel in 8 weeks to check ferritin and hemoglobin. Before she left, she said something I hear often and want to share: "I wanted a single fix. I thought more pills meant more help." I reminded her that often in aging, precision is the real power. Small timing tweaks and targeted tests can make a bigger difference than piling on more supplements. A few practical scenarios and what to do in each. If you take one of these minerals only, if you're taking calcium alone for bone health, focus on dividing the dose, take it with meals, and check a vitamin D level and kidney function periodically. If you take iron alone because of low hemoglobin, try taking it away from calcium and with vitamin C, and aim to check ferritin and CBC in a reasonable follow-up time. If you take zinc alone, especially long-term, ask about a copper check as part of routine surveillance. If you take 2, the most problematic combination is iron plus calcium taken together. That's where a simple timing change pays the biggest dividend. Zinc is often fine with calcium, if not in high doses, but pairings with iron deserve more attention. If you take all 3, this is exactly the situation in my opening line. You may be cancelling the benefits. The solution is not to stop any of them automatically, it's to separate them in time, check labs, and make diet-based adjustments so supplements fill gaps rather than overlap harmfully. Safety reminders, and what to ask your provider. This is general guidance and not a substitute for individualized advice. Before making significant changes, especially if you take prescription medications, have heart disease, kidney disease, or a history of anemia, talk with your clinician. Ask for baseline labs, CBC, ferritin, and basic metabolic panel. If you're on long-term zinc, consider copper testing. If you take acid-reducing medication, discuss how that might affect iron absorption and whether timing changes or different iron forms are appropriate for you. Now, in practical terms, here are a few sample daily schedules people often find workable. These are examples, not prescriptive orders. One workable pattern for many older adults is to take a morning multivitamin without iron if they're using a separate iron supplement. Take iron mid-morning with vitamin C and away from coffee. Take calcium split between lunch and dinner. And take zinc with a meal in the evening at a maintenance dose if indicated. The key principle remains. Separate iron from calcium and dairy by roughly 2 to 3 hours and avoid coffee or tea within an hour of iron. At this point, you might be wondering about sleep, constipation, or gastrointestinal upset from iron. Those are common and manageable. Taking iron with a small snack can reduce nausea, and switching formulations, for example to a slow release or a different salt, can help. But each adjustment has trade-offs with absorption. That's why lab monitoring and clinician guidance are important. We've covered roles, mechanisms, mistakes, and actionable principles. And we've started Patricia's story and put an initial corrective plan in motion. What I want you to carry forward is simple. After 60, timing and monitoring are as important as the pill itself. Splitting calcium, separating iron from calcium and coffee, using zinc thoughtfully, and testing regularly transform good intentions into real results. At our clinic, after we made Patricia's changes, I ordered the follow-up labs and scheduled a check-in. Sometimes the change produces measurable improvement in a few weeks. Sometimes it takes longer. Her case nicely illustrates the balance we aim for. Not reflexively more, but smarter and measured. There are a few nuanced points I should expand on before we pause. First, the role of inflammation and hepcidin. If someone has chronic inflammation from conditions like arthritis, COPD, or low-grade infections, they can have elevated hepcidin. Hepcidin acts like a gatekeeper hormone that locks iron inside cells and reduces absorption from the gut. In those cases, simply changing pill timing may be insufficient. We need to address the inflammatory state and consider alternative strategies under medical supervision. Second, the interaction of zinc and copper is not immediate and dramatic in most cases. But when zinc intake is persistently high, more than a few months, we see gradual shifts. That's why proactive lab checks are a conservative, effective approach rather than a reactive one. Third, let's be practical about pill organizers and lifestyle. The convenience of a single pillbox dose is real, especially for memory support. If you use a pillbox, consider using it for non-interacting meds and supplements together. For example, morning blood pressure medication and non-iron multivitamin. But place iron in a separate compartment for a mid-morning reminder or use a simple visual cue to separate it. Finally, many patients ask, is it worth taking supplements at all? The short answer is yes. Calcium, iron, and zinc all have clear roles, and when used correctly, they support bone strength, oxygen delivery, and energy, and immune and repair functions. The longer answer is that their benefit depends on correct use, timing, dosing strategy, and monitoring, especially after 60. Before we move on to the next part of Patricia's journey and a deeper look at specific lab patterns and adjustments, what a rising ferritin looks like versus inflammatory ferritin, how we interpret borderline copper numbers, and how to prioritize changes if a patient is on multiple interacting medications. Remember this safety line again. This is general information, not medical advice. Talk with your healthcare provider before changing your supplement routine, and bring this video or its notes to your appointment if that helps start the conversation. Patricia left my office with a concrete plan and a sense of relief that the changes were small and reversible. She told me she felt hopeful because she understood the why behind each change. We scheduled labs in 8 weeks and a phone check-in in 3 weeks to troubleshoot any symptoms. On the walk out, she said, "It's amazing that a few timing tweaks might make such a difference." I agreed. Small adjustments, when based on physiology, often yield surprisingly big, practical effects. As we prepare to look at her follow-up labs and the next steps in her management, I want you to think about your own routine. Take a mental inventory. When do you take your calcium? Do you pair your iron with coffee? How long have you been taking zinc? Make a note of what you see and bring it to your clinician. In the next segment, we'll dig into lab interpretation, what patterns of ferritin and hemoglobin tell us, how to read zinc and copper values, and how clinicians decide whether to change formulations, adjust timing, or treat with therapeutic iron. We'll also walk through several more real-world examples so you can recognize these patterns in yourself or a loved one. Until then, remember the central message. After 60, precision beats quantity. Small timing changes and routine lab checks are the must-knows that turn good intentions into real, measurable health gains. If this has been helpful so far, leave a quick comment to tell me which supplements you take, 1, 2, or all 3. And if you have specific lab results you're puzzled about, mention that too. I'll read them and, where appropriate, address common lab patterns in the next section. We'll pick up with Patricia's lab results and the detailed, evidence-based next steps in a moment, exploring how her ferritin and hemoglobin changed and what that told us about the success of the timing strategy, and what we did when one lab didn't move as expected. When Patricia returned for her 8-week follow-up, we were both a little curious and cautiously hopeful. Small timing changes often do yield measurable results, but biology can be stubborn, and it's important to know what different lab patterns actually mean so you and your clinician can respond appropriately. Her labs showed what I see commonly when timing and food interactions are the main problem. Her hemoglobin had risen modestly, which matched her report of slightly more energy on stairs and while carrying groceries. Her ferritin, the storage protein we use as a practical marker of iron reserves, had increased as well, though not as dramatically as we might see with high-dose therapeutic iron. That pattern told me 2 things. First, her intestine had started absorbing more iron after we separated the iron from calcium and coffee. Second, there was steady, gradual repletion rather than a rapid repletion that sometimes needs closer gastrointestinal tolerance checks. In short, the timing change was working. Now let's unpack what different laboratory responses mean and what we commonly do next. Understanding common lab patterns and what they tell us. When clinicians evaluate iron status, we typically look at hemoglobin and a marker of iron stores like ferritin, sometimes alongside transferrin saturation or a complete iron panel. Those numbers don't exist in isolation. They're interpreted in context. If hemoglobin rises and ferritin rises, that's the pattern we want to see when someone has iron deficiency related to low absorption or intake. It suggests iron is getting into the body and being used to manufacture red blood cells. If hemoglobin rises but ferritin doesn't move much, this can happen early in therapy. The body prioritizes making red cells and only later rebuilds storage. It can also occur if there's ongoing blood loss or a persistent inflammation that keeps ferritin deceptively normal. In that case, we look for sources of continued loss, for example, gastrointestinal bleeding, and we reassess inflammation markers. The next step is often to continue therapy while investigating why stores aren't rebuilding. If ferritin rises but hemoglobin is unchanged, occasionally ferritin increases because of inflammation. Ferritin is an acute phase reactant and can go up with infection or chronic inflammatory conditions. If ferritin rises without hemoglobin improvement, we look for signs of inflammation or infection and may run additional tests before assuming iron repletion. If neither ferritin nor hemoglobin moves, start by checking the basics: timing, adherence, and medication interactions. Did the patient actually separate iron from calcium? Are they still taking coffee at the same time? Are they on acid-suppressing medications that blunt iron uptake? If adherence and timing are correct, we consider absorption problems, for example, prior gastric surgery, celiac disease, or other causes of malabsorption, or elevated hepcidin from chronic inflammation. In some of those situations, oral iron isn't enough, and IV iron under specialist care becomes a consideration, but only after careful evaluation and with appropriate monitoring. When labs won't budge, systematic troubleshooting. If you or a loved one follow a timing plan for several weeks and labs don't improve, a systematic approach helps avoid needless guesses. First, verify that supplements are taken as planned. Sometimes a single daily habit, like the coffee mug on the kitchen table, undermines an otherwise perfect schedule. Small practical tweaks matter. Second, review medications. Proton pump inhibitors and H2 blockers are common in older adults and reduce stomach acid, which impairs the conversion of iron into a form that the gut can absorb. If acid suppression is necessary for medical reasons, your clinician may recommend alternative iron formulations, altered timing relative to the medication, or monitoring strategies. Never stop prescribed acid-reducing therapy without your clinician's advice. Third, check for sources of blood loss. Especially in older adults, chronic low-grade gastrointestinal bleeding can cause iron loss that exceeds what oral supplementation can replace. Your clinician may ask about changes in bowel habits, occult blood testing, or a referral to a gastrointestinal specialist if indicated. Fourth, consider malabsorption causes. Conditions like celiac disease, atrophic gastritis, or previous bariatric surgery reduce iron uptake. If there's a clinical suspicion, targeted testing or specialist referral is appropriate. Fifth, evaluate inflammation and hepcidin. Chronic inflammatory conditions raise hepcidin, a hormone that tells the gut to absorb less iron and traps iron inside storage cells. If hepcidin is the problem, treating the underlying inflammation or using alternative iron strategies may be needed, again under clinician supervision. Iron formulations and tolerability. Practical considerations. People often ask whether one iron supplement is better than another. In broad strokes, different iron salts, ferrous sulfate, ferrous gluconate, ferrous fumarate, and formulations, slow-release, enteric-coated, liquid, hemi-iron supplements, vary in how much elemental iron they provide and how well tolerated they are. A few practical points I share with patients. More absorption often comes with more gastrointestinal symptoms, so a formulation that's gentler on the stomach may be better tolerated, but can sometimes deliver less usable iron. That trade-off matters if someone cannot adhere because of nausea, constipation, or abdominal discomfort. Slow release or enteric-coated iron may reduce stomach upset, but can also bypass the region of the small intestine where iron absorption is best, decreasing effectiveness. That's why some clinicians recommend taking gentler formulations, but monitoring labs closely to ensure effect. Hemi-iron, derived from animal sources, is generally absorbed better and is less affected by dietary inhibitors, but it's not appropriate or acceptable for everyone. For those who tolerate it and for whom dietary patterns allow, it can be a useful option. If oral iron proves intolerable or ineffective after a careful evidence-based trial, IV iron is sometimes necessary and effective, especially when blood loss is ongoing, absorption is impaired, or rapid repletion is needed. IV iron must be managed in a medical setting with appropriate monitoring. Remember, any formulation change or initiation of IV therapy should be coordinated with your treating clinician. Zinc and copper, when to worry and what to check. Zinc is often part of the supplement conversation because of its roles in immunity and wound healing. The risk with zinc is largely cumulative. High, prolonged intake can reduce copper absorption, and copper is essential for iron metabolism. Low copper can therefore contribute to anemia and to neuropathy in some cases. If you take zinc daily for months or longer, a reasonable approach is periodic lab checks that may include copper levels and clinical assessment for signs of neuropathy, numbness, tingling, balance changes. If zinc has been started to treat a specific short-term episode, for example, a brief course during an upper respiratory illness, long-term risk is lower. If labs suggest copper is slipping, the clinician will weigh the risks and benefits of reducing zinc, adding copper, or altering the overall plan. Important lifestyle and dietary tactics that help absorption. Some practical, food-centered steps often get overlooked because they seem too small to matter, but they do. Pair iron-containing meals with vitamin C, a portion of fruit, a squeeze of lemon, or a small glass of orange juice enhances iron uptake from both plant and supplemental iron. Even a couple of tablespoons of tomato sauce or raw bell pepper with a meal can help. Avoid tea or coffee within an hour before and after iron. The polyphenols in these beverages bind iron and reduce absorption. Cook in a cast iron pan now and then. Food cooked in iron cookware gains small amounts of dietary iron. This is a low-risk, food-first strategy that complements supplements. Choose heme-iron foods if your diet allows them. Red meat, poultry, and fish contain iron that's more readily absorbed than plant sources. When eating plant-based iron, pair those foods with vitamin C to enhance uptake. For calcium, focus on calcium-rich meals rather than isolated pills when appropriate. But when supplements are necessary, split your dose rather than taking a single large amount. Practical routines, a few realistic templates that patients use. People want simple, sustainable plans. Below, I describe a few sample routines that respect the separation principle. These are illustrative, not prescriptive, and should be adjusted with clinician input. Example A. Multivitamin without iron. Separate iron supplement. Take a general multivitamin with breakfast if it does not contain iron. Take iron mid-morning about 2 hours after breakfast, with a source of vitamin C and away from coffee. Take half the day's calcium at lunch and the other half with dinner. Take zinc with dinner if indicated, and in a moderate amount. Example B. If you need therapeutic iron and take morning medications, take prescribed morning medications with a small amount of food as directed. Take iron mid-morning or mid-afternoon with vitamin C. Take calcium with meals later in the day. Check labs at the clinician's recommended intervals. Example C. Minimal supplements. If you only take one mineral, for example calcium for bone health, divide the calcium into 2 doses with meals and ensure adequate vitamin D status. If you take iron only, try to schedule it away from calcium and tea, coffee, and pair with vitamin C. Caveats about specific medications and special situations. A few scenarios require extra vigilance. Acid-reducing drugs. As noted earlier, these reduce iron absorption, particularly non-heme iron. Discuss alternatives and timing with your provider. Sometimes different formulations or dosing plans work better. Kidney disease. Kidney function affects mineral handling, including calcium and phosphate balance. If you have reduced kidney function, your clinician will tailor mineral goals and monitoring to your situation. By bariatric surgery or gastric bypass. These surgeries change the anatomy and physiology of the gut in ways that commonly reduce iron and other mineral absorption. People with prior bariatric procedures often need higher vigilance and sometimes long-term specialized supplementation under medical guidance. Vegetarian or vegan diets. Plant-based diets can be rich and healthy, but often deliver non-heme iron, which is less readily absorbed. Pairing plant iron with vitamin C and minimizing inhibitors around iron intake helps. Clinician monitoring is still the cornerstone. How long to try changes before reassessing? A practical, conservative timeline many clinicians use is to recheck hemoglobin and ferritin about 6 to 12 weeks after correcting timing and improving adherence. That window lets us see whether the intestine is absorbing enough iron to rebuild stores and correct anemia. If symptoms are severe or labs are very abnormal, we may check sooner. For zinc, copper, labs may be spaced longer, often several months, unless symptoms suggest a faster problem. Sample language you can bring to your clinician. When you meet your clinician, it helps to be specific and practical. You might say, I'm taking calcium, iron and zinc. I separate the iron from calcium by about 2 to 3 hours and take iron with vitamin C. Could we check a CBC and ferritin in 8 weeks to see if that's working? Also, I've been taking zinc daily for months. Should we check copper? That opens a focused, collaborative conversation and invites lab monitoring rather than guesswork. Common questions I hear and brief answers. Can I take my iron with food if it bothers my stomach? Yes, a small snack can reduce nausea. It may lower absorption slightly compared with taking iron empty, but better adherence often outweighs the small loss of absorption. The important part is consistency and follow-up labs. Is it okay to take a single multivitamin that contains iron with breakfast? If you also take calcium at breakfast or drink coffee with that meal, you may be blunting iron absorption. Consider separating the iron-containing supplement from calcium and from coffee, or ask your clinician whether a non-iron multivitamin plus a separate iron supplement might suit your needs better. Should I stop zinc if my copper is low? Don't stop or change doses on your own. Talk with your clinician. Often the right response is to reduce zinc, reassess dietary copper, and check levels again. Sometimes a short course of copper repletion or dietary counseling is used, but it depends on the clinical picture. Can I take calcium at night? Yes, many people take part of their calcium with dinner or before bed. The main point is to split the dose, rather than taking it all at once, and to avoid placing calcium and iron together. Bringing the conversation back to Patricia. When Patricia's labs improved modestly at 8 weeks, she reported more energy and less shortness of breath while walking upstairs. Her ferritin was rising, her hemoglobin was increasing, and she tolerated the mid-morning iron with a small glass of orange juice. We repeated zinc copper labs at 3 months and saw a stable copper level, so no further action was required. Her calcium was split between lunch and dinner, and she reported fewer gastrointestinal complaints than when she had taken everything at once with yogurt and coffee. She told me the change felt sustainable and not onerous, and that she liked understanding the why behind every step. A concise checklist to take away. Keep these key actions in mind. They are the must-knows for anyone over 60 who uses calcium, iron and zinc. Separate iron from calcium and dairy by roughly 2 to 3 hours whenever possible, and avoid coffee or tea around iron doses. Pair iron with vitamin C for better absorption. Split calcium into smaller servings across the day, for example, into 2 servings, rather than taking one large dose. Use zinc thoughtfully. Avoid long-term high doses without periodic lab monitoring for copper. Favor a food-first approach where possible. Use supplements to fill gaps identified by diet assessment and labs. Get baseline labs, CBC, ferritin, basic metabolic panel, and repeat them at clinician-recommended intervals, commonly around 6 to 12 weeks after a change. And add copper-zinc testing when long-term zinc or unusual symptoms are present. Final safety reminder. This information is general and educational, not medical advice. Before making major changes to your supplement routine, particularly if you have chronic illnesses, take prescription medications, or have significant lab abnormalities, Talk with your healthcare provider. Bring notes about what you take and when you take it. That makes the evaluation faster and more precise. A few closing thoughts, and what I want you to remember. You did the right thing by caring about bone health, energy, and immune resilience. Calcium, iron, and zinc are powerful and useful supplements. They're not villains. After 60, the challenge shifts from more is better to smarter is better. Timing, separation, and monitoring turn well-intentioned routines into effective care. If you walk away with one practical must from this video, let it be this. Don't assume that taking all your minerals together is getting the job done. Separate iron from calcium and coffee, split your calcium, use zinc with caution long-term, and ask your clinician for the labs that tell the real story. If this video helped you, please hit like and subscribe for more evidence-based healthy aging guidance. In the comments, tell me, are you taking 1, 2, or all 3 of these minerals? If you're comfortable, share your most recent ferritin or hemoglobin numbers and any symptoms you're tracking. I'll use common patterns in future videos to answer frequent questions. And one last time, this is general information, not individualized medical advice. Talk with your healthcare provider before making significant changes to your supplement plan, and consider bringing this video as a conversation starter. If you're over 60, you must know this about calcium, iron, and zinc. Timing and monitoring are the simple, high-impact changes that turn good intentions into real results. Small adjustments often make the biggest difference. Thank you for spending this time with me. I look forward to answering your questions and helping you make practical, sustainable changes for healthier aging.